presentation. It looks like it smells like it, so it must be glaucoma. I'm Dr. Carolyn Majcher, a full-time associate professor and the director of residency programs here at the Oklahoma College of Optometry. And it's such an honor to be joined for this lecture by Dr. Jessica Steen. And Jessica, could you please tell us a little bit about yourself?
Thanks, Carolyn. It's so good to be with you, to see you across the screen, across the country. I am an assistant professor at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida, where I serve as director of our glaucoma service. So I think we're going to have a really nice conversation about some of these challenging cases that may or may not be what we think they may be at first sight.
Oh, it's such a pleasure to have you here. And the purpose of this lecture, as you kind of mentioned, is to explore a case series of glaucoma masqueraders, these complex, challenging cases. And throughout each case presentation, really highlight and recognize perhaps those features that are inconsistent with the diagnosis of glaucoma, maybe suggestive of something else or something else in addition to glaucoma. And by way of disclosures, I'm a paid speaker and consultant for Zeiss and Regeneron Pharmaceuticals, and also a paid advisory board member of Apellis. And so without further ado, let's just dive right into our first case entitled "Fool Me Once, Shame on You, Fool Me Twice, and Not After This Case." This was a 59-year-old male who was diagnosed with primary open-angle glaucoma and started on topical meds about 7 years ago, but then later had SLT performed in 2017 due to poor drop compliance. His highest intraocular pressures untreated were slightly elevated, so 23 in the right and 20 in the left. However, he responded very nicely to SLT with post-laser pressures of 15 in the right, 13 in the left. His medical history, definitely some things we need to talk about there. Remarkable for 2 ischemic strokes in 2006 and 2019. And we know that the most recent stroke involved the left pons and frontal lobe. However, the exact location of the brain that was damaged with the stroke in 2006 was unknown because it was so long ago, we didn't have that information in our records. He had a CT angiogram performed after that second stroke in 2019, and that angiogram revealed some occlusion or perhaps severe stenosis of the left posterior cerebral artery beyond the P2 segment. And so it's likely, based on those findings, that the first stroke involved infarction of the left posterior cerebral artery. In addition to stroke, he has some risk factors for stroke systemically, right? So hypertension, diabetes, and dyslipidemia. His best corrected acuities in the right eye 20/20, the left eye 20/20 -1. External is unremarkable. His intraocular pressure is within normal range here on this visit, so 17 in the right eye, 15 in the left. Anterior segment, just some trace cataracts, open angles. His PAC's 518 in the right, 528 in the left eye, so a little on the thinner side. So we know that we're slightly underestimating the true intraocular pressure with Goldman applanation tonometry. And then looking here at his color fundus photographs of the optic nerve head, you can appreciate there's some asymmetric cupping, right? The cup to disc ratio looks a little bit larger on the right eye than it does on the left eye. There is also, I think, some temporal neuroretinal rim pallor, more so on the right eye again compared to the left eye. And anytime you have optic nerve head pallor, that's something that should raise a red flag for you and say, this probably isn't glaucoma, this is probably something else. We don't expect to have neuroretinal rim pallor in early or moderate stage glaucoma. The other thing I want to point out here is some arterial attenuation that's pretty diffuse in both eyes. And so that arterial attenuation may be suggestive of some vascular etiology to this neuropathy that we're seeing. And Jessica, I'd love to get your thoughts on looking at these optic nerve heads. Is there anything else that might be noticeable to you?
You know, they're really nice photos where you can really appreciate the retinal nerve fiber layer reflectance. And, you know, right away, there are no focal nerve fiber layer defects, maybe some mild slit defect, inferior temporal, but certainly nothing that extends to the optic nerve. So there is clearly no focal wedge defect that would be consistent with glaucoma. The rim tissue overall does look well established. There's no focal notching or focal loss of the neuroretinal rim tissue either.
Excellent points. Like you mentioned, I think having that robust nerve fiber layer superior and inferiorly is really suggestive of something going on other than glaucoma. Couldn't agree with you more on that. And these are his optic nerve head OCTs from 2020 and then 2018 over here on the right. On the 2020 scan, we can appreciate that there's some temporal nerve fiber layer thinning on both eyes, but perhaps the right eye is a little bit more worse than is the left eye. There's also some asymmetry on the Tisnet curve here that I want to point out. That's maybe a little bit more subtle, where it's suggestive of NFL loss nasally here in the right eye compared to the left. And this pattern of nerve fiber layer loss seems pretty stable compared to 2 years ago from 2018. Then here are his macular GCC scans, again from 2020 here on the left-hand side to 2018 on the right. There's some hemimacular GCC loss, with the right eye exhibiting this nasal hemifield loss, the left eye exhibiting this temporal hemifield loss. And this GCC loss, I think in both eyes, is a little bit worse inferiorly as opposed to superiorly. It also seems to respect the vertical. And what I mean by that is if we dropped a vertical meridian straight down through the center of the fovea, it seems to somewhat respect that. Certainly this hemiopic pattern of GCC loss in vertical respect is atypical for glaucomatous damage. We know glaucomatous damage tends to respect the horizontal raphe. And these findings on GCC are pretty consistent and stable based with what we see here in 2018. So this is one of his prior visual fields from early 2019. And in both eyes appear to have this dense superior arcuate defect and possibly even some horizontal respect here in the left eye. So I think it's really easy to see how you could look at this field and maybe not putting all the rest of the pieces of the puzzle together and say, oh, this field looks glaucomatous, how easy it could be to follow along with that diagnosis in this case based on the visual field findings. But remember, making a diagnosis of glaucoma, we can't rely on just one single test, right? It's putting together pieces of a puzzle. We're looking at structural and functional tests. We're saying, do they correlate and fit with each other? And in this case, however, we see there's poor correlation between our structure and function. If we have such dense superior visual field loss, we're going to expect there to be substantial loss in the inferior nerve fiber layer, which we're not seeing on our OCT. So when we have this disagreement between our structural and functional tests, it's going to raise suspicion that maybe one of our tests isn't reliable, that there's an artifact on one of these tests, or perhaps there's a non-glaucomatous cause to the neuropathy that we're seeing. And so in this case, we decided to bring the patient back and repeat the visual field with the lids taped. And so here is the visual field with the lids taped 1 month after that visual field I just showed you. And we can now appreciate that there is right-sided visual field loss in both eyes. So we're looking at a right incongruous homonymous hemianopia, denser superiorly, with perhaps some vertical respect here in both eyes as well. And so, Jessica, before we dive into this case discussion, I'd love to pick your brain and see how are you going to manage this case based on the information I've given you thus far?
So this patient has been treated for glaucoma. They had poor adherence to medical therapy. They responded remarkably well to SLT, but I don't see any evidence of true glaucomatous damage when we're putting these pieces together. This is someone who I would opt to follow without medical therapy as far as intraocular pressure lowering therapy, whether that be medication or repeat SLT. I don't think this patient has glaucoma.
I couldn't agree with you more. And I think especially now with his pressures being within the normal range, there's nothing more for us to do here. And it's been stable, right? So glaucoma should progress, right? If this is something that's stable, it's probably something else. And so I'd like to review the red flags in this case that should raise suspicion in your mind for a non-glaucomatous etiology. And the first is going to be the vertical respect and hemianopic pattern of both our visual field loss and the GCC loss. We have this nasal and temporal aspect to the nerve fiber layer loss, where with glaucoma, right, we would typically expect the nerve fiber layer loss to be more superior and inferior. They're vertically oriented. We also saw that disc pallor on the optic nerve of the right eye temporally. And so that's another red flag. This is probably something other than glaucoma. And so I believe that our patient's neurofiber layer and GCC loss can be attributed solely to a retrochiasmal visual pathway lesion. And our patient's visual field defect is a right homonymous hemianopia. So we kind of break this down. We know that the visual pathway lesion is on the contralateral side, so on the left-hand side. We would expect then that there would be temporal nerve fiber layer loss and GCC loss in the eye ipsilateral to the lesion, which is the left eye in this case. And then in the eye contralateral to the lesion, we're going to expect some nasal NFL loss, as well as some damage to that papulomacular bundle fibers that cross in the chiasm as well. And that's going to correspond to temporal neuroretinal rim pallor, temporal nerve fiber layer thinning that we see on our OCT, and then also this nasal GCC loss there in the contralateral right eye. So based on his CTA and visual field findings, I believe our patient likely had a past infarction of the optic radiations within the temporal lobe, but could have also suffered an insult on the level of the occipital lobe. And recall that his CT angiogram from 2019 showed that there was occlusion of the posterior cerebral artery beyond that P2 segment. And we know that branches of the P2 segment beyond there go to supply the temporal lobe and the occipital lobe. Right, but I think our patient's visual field defect best matches that of an optic radiations lesion. So recall that the optic radiation fibers in the temporal lobe carry information from the superior visual field. So when they are insulted or infarcted in this case, it results in an incongruous homonymous hemianopia denser superiorly, which is what our patient exhibited. So it's important, I think, for us to be aware of the fact that retrochiasmal visual pathway infarctions, even all the way back in the occipital lobe, can cause GCC loss via a mechanism called retrograde ganglion cell degeneration. And retrograde ganglion cell degeneration results when there's damage to, say, the optic tract, and you have atrophy back towards the cell body, in this case, the ganglion cell body. We can also, there's a term described as transsynaptic retrograde ganglion cell degeneration. When the degeneration is located, say, in the optic radiations or occipital lobe, and that atrophy has to cross the synapse at the LGN, but ultimately still results in damage to the ganglion cell bodies. So retrochiasmal lesions at any location can result in corresponding hemimacular GCC thinning. And research shows that the more anterior the lesion of the, say, optic tract or LGN are going to result in faster and more severe GCC loss. The majority of the hemimacular GCC thinning tended to occur within 6 months, and most of cases stabilized at 2 years. So let's say in our case, we're seeing progression after 2 years, right? We think it's just retrochiasmal ganglion cell degeneration, but we're seeing progression after 2 years. That's suggestive of perhaps repeated strokes that weren't caught, or maybe some other cause of neuropathy like glaucoma on top of this damage that he already has. And with that, I'm going to pass it over to you, Jessica.
Thank you. So every cause has at least one effect. So this is a 63-year-old Han Chinese female who was referred to our glaucoma service for suspicion of glaucoma. Now, she is highly myopic. She has good central visual acuity. She's systemically well. Her pupils were within a normative range, no afferent defect in either eye, and she has normal color vision in each eye. Now, color vision is something that I do like to pay attention to in individuals who may be suspicious of having glaucoma, because we expect that color vision is not impacted in patients with glaucoma in early or even moderate disease. Now, as disease advances, certainly there can be color vision deficits, but in early stages, we do expect the color vision to be unaffected in patients who have glaucoma. Now, central corneal thickness is thin. When we're talking about the concern or suspicion of glaucoma, it's all about risk analysis. And, we have many risk factors that we evaluate when we're thinking about suspicion of glaucoma. Certainly, central corneal thickness is a significant risk. Now, this individual's corneal thickness, about 500 microns in each eye. My personal preference is to use light-based technology to measure central corneal thickness, in this case an OCT, versus using ultrasonography as based in OATS. And the reason why is that when we use light-based technology, we get this overall map. It allows us some sort of context of where that central corneal thickness measurement is really coming from. If we're and when we're measuring corneal thickness using ultrasonography, it is highly unlikely that we are going to be perfectly in the anatomical center of the cornea to get the true central corneal thickness measurement. So if we're anywhere outside of that perfect center, we're going to slightly overestimate the central corneal thickness. Now, even though this individual is highly myopic, evaluation of the anterior chamber and the angle is certainly something that needs to be done, and we need to be comfortable with evaluating by gonioscopy. Now, we know that East Asian individuals have a much greater likelihood of angle closure disease than our patients in a North American population. And, as axial elongation happens, while the posterior segment of the eye increases in size, the anterior segment of the eye may not. And the typical risk factors that are associated with angle closure spectrum disease related to the lens anatomy and the iris anatomy are not impacted in high myopia. So even in our high myopes, we do need to worry about angle closure disease. So why is it so difficult to evaluate optic nerves in myopic individuals? It's all related to the anatomical and axial elongation that causes scleral and retinal stretch. Now, when we really look at the optic nerve and the lamina cribrosa are also horizontally elongated, are elongated. That creates more of a shallow cup than what we're typically expecting to see in a less myopic eye, which can make it difficult to really discern the anatomical cup from the neuroretinal rim. Certainly we also have a very large area of parapapillary atrophy, and we see this characteristic kind of narrowing of the angle between the superior temporal and inferior temporal arcade. And that's something anatomically important that when we look at nerve fiber layer imaging, this kind of anatomical temporal shift of where we expect the typical retinal nerve fiber layer thick bundles to be does have an impact. So in this case, the right optic nerve, we have optic disc tilt, we have oblique insertion. And if we're really following where the neuroretinal rim where the inner margin of the neuroretinal rim is, this looks like healthy rim tissue. There's no focal area of notching with overall a moderate vertical cup to disc ratio. In the left eye, the left optic nerve, a much smaller optic cup, a very shallow optic cup. Looking at these optic nerves, this is an individual that my suspicion of glaucoma overall is very low on going in. Now, nerve fiber layer imaging is often a very helpful structural tool. It is unfortunately much less helpful in highly myopic eyes. Part of this challenge is able to actually image the entire optic nerve within the imaging area. We also have to worry and think about segmentation error. That is something to think about in any individual that we're imaging, but especially in eyes that may have either pathology or that are highly myopic. And what segmentation error refers to is this mismatch or this inability of the automated OCT software to discern the anatomical margins that are needed for nerve fiber layer assessment and for optic disc evaluation and measurements. So what we see, if we really just focus on the nerve fiber layer thickness map, this heat map superior and in the right eye, what we see is nerve fiber layer thickness bundles, superior temporal and inferior temporal. This overall does look like a fairly robust retinal nerve fiber layer in the right eye. In the left eye, we have lots of areas of missing data that, really was just a challenging image to gather. We also see an optic nerve that looks very different from what we saw clinically. And, when we think about the anatomical basis for OCT boundaries, we have to think about where Brooks membrane opening is. And if we look at this cross-sectional scan, we can see very carefully when we really, really look in that the margin of Brooks membrane opening is shifted far away, far nasal in this case, from where we would expect it to structurally be. And, we're really seeing this poor reflection of the OCT in what we saw clinically. Segmentation error is common. We always need to keep it in mind. And, for these highly myopic eyes, we do also have to think about how our patients' features may be reflected in a normative database. And this is an image from the Zeiss Cirrus device. And while the normative database for this device does include individuals up to -12 diopters, we know that the number of highly myopic individuals included is going to be very small. So we always have to think of whether or not the patient that we're imaging is appropriately or adequately reflected by the data in a normative database. And in this case, this individual is not well reflected in a normative database, which makes much of the comparison data something that's challenging in and of itself. Now, sometimes in myopic eyes, the ganglion cell complex and ganglion cell analysis can provide us with more useful information. And that's because typically, however, not always, the macular structure in a highly myopic eye is less impacted than the optic nerve structure. So if we look at the right ganglion cell complex analysis, overall, we see fairly robust ganglion cell thickness with this inferior kind of gap or loss of ganglion cell thickness. Carolyn, any thoughts on whether or not this follows a typical glaucomatous pattern?
Yeah, to me, it really doesn't seem to. And the reason is that the ganglion cell loss doesn't seem to respect that horizontal raphe. Again, it's kind of just this blob inferiorly. And so to me, that's suggestive of something else. Maybe that's, the myopia, or perhaps that's just segmentation error here again.
Mm-hmm. Exactly. And, when we're looking at the retinal nerve fiber layer thickness, there is a measurable retinal nerve fiber layer bundle without a focal inferior temporal defect that appears glaucomatous. So we don't have that correlation in this case. In the left eye, overall, a fairly symmetric ganglion cell complex analysis that's here that doesn't have, again, that characteristic nautilus shell or squeegee sign that we might expect. So let's look at the functional aspect. Now, this is this patient's first visual field, and it was a challenge for her. When we look at the right eye, we see that kind of clover leaf pattern with generalized depression in both eyes. And one of the markers that I like to keep in mind, and one of the parameters that I like to turn on our automated visual fields, is the foveal threshold sensitivity. It's kind of one more check as to say, does what the patient sees, or is the patient's central visual acuity, does that correlate with what we expect on foveal threshold sensitivity? For an individual who is 20/25 or 20/20, we would expect foveal threshold sensitivity in the ballpark, depending on the patient's age, somewhere between about 32 and about 36 or 37 decibels. And in this case, we see in the low 20s. So we made this visual field a lot harder for this individual than it needed to be. She's highly myopic, and the trial lens power was calculated based on a plano individual with a +325 lens. So we tried it again. And the quality of the visual field improved. We also performed a different testing strategy. This is the 24-2C, CETA faster. Now, what that C means is that there are an additional 10 points that are tested in the paracentral area. And these points were gathered based on the location of the 10 most frequently impacted points on the 10-2 visual field. So it's kind of a combination of a 24-2 pattern with these additional 10-2 most commonly impacted points. In the right eye, we see inferior visual field loss that did not correlate with what we saw clinically. In the left eye, maybe an enlarged blind spot with few superior missed points. So we gave it a shot on another day, and this day wasn't quite as good for this individual. Once again, generalized depression, maybe an enlarged blind spot in the left eye. So when we think about this piece and putting these risk factors together, the major risk factor that we think about in glaucoma is intraocular pressure. And this was something that I particularly did leave until this point. We know that when we're thinking about diagnosing glaucoma, we've got to take intraocular pressure really out of the equation. While elevated intraocular pressure is a significant risk factor for development of glaucoma, we know that individuals can develop glaucoma and do develop glaucoma with a wide range of intraocular pressures. We also see, as being in a teaching institution, often intraocular pressure is measured more than once on the same clinic day, often by an intern and repeated by either a resident or attending. So we do often see sometimes those differences. But as we see our highest or peak intraocular pressure, 21 millimeters mercury with a thin central corneal thickness, we do have risk factors for disease development. But when we look at this entire picture, we don't have the typical structural and functional correlation that we expect. This is an individual that we are still monitoring without treatment. She is due for her scheduled 6-month follow-up and is on our schedule for her 6-month follow-up next week. We are periodically reevaluating her testing, evaluating for any progressive change over time that is characteristic of glaucoma. Now, just to touch on one similar case, this is a 64-year-old Black female, also myopic. Now, what we see in this individual's case that I really want to focus in on is in the left parafoveal area. We see an area of macular atrophy just inferior to the center of the fovea. So when we think about functional damage or functional impact of macular atrophy, we do have to keep in mind that while this patient's central acuity is 20/20 minus, there certainly can be paracentral scotomas based on what we see clinically in the paramacular area. Now, this individual was diagnosed with glaucoma in 2016 with a peak pressure of about 25 millimeters mercury in each eye with fairly average central corneal thickness based on the visual field characteristic pattern. We see a really typical nice nasal step in the right eye and the left eye. She was placed on an intraocular pressure lowering medicine, latanoprost, in both eyes. Peak pressure 25, on treatment about 18 millimeters mercury, and had been relatively stable. We see once again in these myopic eyes, OCT of the retinal nerve fiber layer is not our most valuable tool, and just the challenge that the device itself has in determining the margins of the optic disc and optic cup. Now, in this individual over time, we have seen an increase in her myopia in the left eye, about 2 diopters since she was initially diagnosed with glaucoma. Now, this macular atrophic change we see based on OCT cross-section, that there is loss of the RPE and overlying photoreceptors. This will cause a scotoma. So what does her functional imaging look like? We're really paying attention to this left eye. We're now seeing a superior paracentral scotoma in a very similar position as where we saw this area of macular atrophy. So is this progression from a nasal step to a paracentral scotoma due to glaucomatous disease progression? Or is this change in retinal structure and scleral stretching with further axial elongation causing this paracentral scotoma? Our options in this case, her intraocular pressure is 18 millimeters mercury. Our options are to do something or to do nothing. And considering this progression that we have documented over time in the left eye, we, as myself and the patient, came to the decision that we would do something, which is to further lower the intraocular pressure, knowing that this may not be glaucomatous progression, this could be myopic retinal change, but choosing to modify the only modifiable risk factor that we can in this patient's case. So when we talk about myopia, we know myopia is one of those additional risk factors to keep in mind for the development and progression of glaucoma. And very recently, there was a well-done meta-analysis that reported that as the amount or level of myopia increases, 6 diopters, 8 diopters of myopia, there is a nonlinear increase in the risk of developing glaucoma. So this is truly expected and in the sense that, or described in the sense to be of a mechanical nature, that as there is scleral expansion and axial elongation, that not only stresses and stretches the retinal tissue, but also stresses and shears the lamina cribrosa. And as the axons pass through the lamina, they're much more susceptible to that shearing stress and damage that occurs in glaucoma. Now, the other question is, as we've seen, it can be very difficult to differentiate retinal change and progression from maybe optic nerve change and structural and functional progression in individuals who may be suspicious of or may have glaucoma who are highly myopic. So is it possibly that, especially in these highly myopic eyes, that we may be over-diagnosing glaucoma in these particular individuals? You know, the myopia glaucoma conundrum is one of the most difficult types of cases that we deal with. And, you know, it really is about balancing the risks and the potential benefits of treatment versus observation, really on an individual basis.
I think you brought up some excellent points there, Jessica. And I'd like to add that if you have atrophy around the optic nerve, so peripapillary atrophy, you're going to expect that to cause an enlarged blind spot, which you definitely had on your visual fields there. And then also, if you're seeing these atrophic areas of RPE in the macular region in these patients with high myopia, that typically, like retinal choroidal disease on the visual field, doesn't respect the horizontal, whereas, you know, glaucomatous visual field loss should respect the horizontal. But excellent case. Thank you so much. Moving on to case number 3, expect the unexpected. And this was a 50-year-old American Indian male, and he presented to our glaucoma clinic coming in for a follow-up on pigmentary glaucoma that he was diagnosed with in both eyes 20 years ago. He had already had SLT performed back in 2009. In addition, he had been using latanoprost in both eyes, and I don't even know when that started because it had gone back so many years. I couldn't even find the start date in any of our records. His highest IOPs that I could find within the records I had, which was about 10 years, was 18 in the right eye, 19 in the left. But this was in 2016 when he was on latanoprost. So we don't know what his true untreated intraocular pressure was. His medical history was remarkable for a pretty severe car accident that happened 20 years ago, and that resulted in head trauma that was severe enough that he had facial reconstructive surgery done. His best corrected acuity, the right eye 20/20, the left eye was slightly reduced at 20/30, pinhole, no improvement. Again, I want to point this out as a red flag that if you're having decreased visual acuity, that's suggesting something other than glaucoma. And like you brought up, Jessica, earlier, that color vision shouldn't be affected in early stage glaucoma as well, similar with visual acuity. External testing was normal aside from some temporal visual field loss with confrontation visual field testing. Again, this is a red flag. We shouldn't have temporal visual field loss with moderate or early stage glaucoma. His intraocular pressure is definitely in the normal range here at this point, 14, and symmetrical in both eyes. Anterior segment, there was a little bit of endothelial pigmentation that we would expect with pigment dispersion. His angles were open, pachymetry pretty average. And then gonioscopy did reveal open angles, no angle recession of note due to that history of trauma. We did see about 2+ pigment. Now, typically in pigment dispersion, we would expect the trabecular meshwork pigment to really be hot and heavy, right? Like a 4+ pigment. And so the fact that we're only seeing like 2+ pigmentation at this point, I think is suggestive that, you know, he's 50 years old. He's probably in this like burnout phase of pigment dispersion where there's not as much rubbing of the lens zonules to the posterior epithelium of the iris. So less pigment is being released at this case due to aging anatomical changes. Here are his optic nerve head photographs, and we can appreciate that there's some fairly large cups in both eyes, about 0.5, 0.6-ish cup to disc ratio there, but it looks pretty symmetric between the left and the right eye. So we would expect that any sort of damage we're going to see on our structural or functional ancillary testing from here on out is going to also be pretty symmetric. The color of the neuroretinal rim tissue looks pretty good. You might be able to argue there's some temporal neuroretinal rim pallor if you're like really overanalyzing it, like I sometimes tend to do. And this is his optic nerve head OCT from when I first saw the patient in 2019. And in the right eye, the nerve fiber layer is, pretty much within normal limits, 360 there. The left eye, however, has the severe diffuse GCC loss. That's a bit worse nasal and temporal. And it looks a lot worse than the disc appearance that we just saw, that like 0.5, 0.6 cup. We wouldn't expect that much nerve fiber layer loss with that cup appearance. And so this is his OCT guided progression analysis of the right eye. And we're fortunate enough to have data on him from a 10-year span. So this goes from 2009 all the way to 2019. And there's possibly some mild progression as signified by these orange boxes here. His average NFL thickness has gone from 89 to 81, but this 81 average NFL thickness was normal on our single scan analysis when we compared to the normative database here, it's in green. And so I think that the progression we may be seeing here is just due to aging effects rather than glaucoma. This is now his guided progression analysis of the left eye, again, over a 10-year span from 2009 to 2019. And it looks pretty stable. His average NFL has been, around the 60th range, aside from this scan in 2019 where it hits 54. However, this is a poor signal strength scan, which I think probably accounts for that change. I want to also point out that, when you've had this severe nerve fiber layer loss, OCT isn't the best way to monitor for progression, right? Visual field or functional test is probably going to be able to give you more information about progression in a case like this. These are his GCC scans from 2009 and 2019, again, 10 years apart. And so in the 2019 scan, we can appreciate that there's some mild generalized GCC loss there in the right eye, a little bit worse inferiorly. And then in the right eye, we have some severe diffuse loss of the GCC. And let's compare that back to 2019. So the right eye, it looks like maybe it's progressed slightly. However, there is a lower signal strength on this more recent scan that may account for some of that apparent progression. The left eye, again, OCT is not the best way to monitor for progression here, but on both cases, it seems in 2009 and 2019, the GCC loss was pretty severe and stable. Here are his visual fields from 2018, which was 1 year prior to me doing my first exam on the patient. And you can appreciate there's some generalized depression in both eyes, but is again very asymmetric, worse in the left eye. The left eye visual field loss also appears to be worse on the temporal side and perhaps respect the vertical meridian. And so when you have visual field loss worse on the temporal side than the nasal side, that's definitely suggestive of something other than glaucoma. We would expect glaucoma's visual field loss to be worse on the nasal aspect of the visual field compared to the temporal side. I think also this degree of asymmetry that we see in our structural and functional tests really echoing that this probably isn't glaucoma, there's something else, this huge asymmetric change. These are now his most recent visual fields from 2019 when I saw the patient. And the left eye continues to demonstrate this dense temporal defect, but we're not seeing as much vertical respect on this scan as we did in the visual field from 1 year ago. The right eye visual field, pretty clean. There's a few scattered depressed points. The GHT is borderline. However, there's no superior visual field loss that would correspond with this inferior GCC loss we saw earlier. So some red flags I really want to highlight and point out again in this case that are suggestive of a non-glaucomatous etiology. There's this huge degree of asymmetry and much more damage in the left eye than the right. We had decreased acuity in the left eye of 20/30. The visual field defect in the left eye was denser on the temporal hemifield versus the nasal hemifield. There was also possibly some vertical respect on that one field that wasn't repeatable, but vertical respect certainly isn't suggestive of glaucomatous loss. Our nerve fiber layer loss in the left eye was mostly horizontal in nature, so nasal and temporal, whereas with glaucoma, we would expect it to be superior and inferiorly. We also had poor correlation between the optic nerve head appearance, where the neuroretinal rim tissue actually looked pretty good, And then we're seeing a whole lot of nerve fiber layer loss and visual field loss. There's that disconnect in our testing that we're seeing as well, that I think is telling us this is probably something other than glaucoma. So I was most concerned in this case about an anterior chiasmal compression, perhaps from a pituitary tumor, since the visual field loss was mostly temporal in nature in the left eye. And so I ordered a CT scan, and it gave me an answer, I think just not the one I was expecting to find. And the CT showed normal parastellar findings, meaning the pituitary gland was normal, there was no tumor there, but it did demonstrate a chronic medial blowout deformity of the left orbital wall. Right, and this makes total sense now that if we have damage to the medial optic nerve that contains the nasal retinal fibers, that corresponds beautifully with our temporal visual field defect that we saw there in the left eye. And so undoubtedly in my mind, there's some traumatic optic neuropathy of the left eye, but are there also features of pigment dispersion glaucoma present? Remember that the right eye had some inferior GCC loss, but didn't have any corresponding field loss. The NFL was good in the left eye. And again, Dr. Steen, Jessica, I'd love to get your opinion on this case. How would you have managed it?
You know, this is an individual that when we're looking at that risk stratification and overall risk profile, you know, you mentioned something very important, that on gonioscopy, there was not that 4+ heavy pigmented trabecular meshwork that we expect to see, and truly we need to see for that diagnosis of pigment dispersion or pigmentary glaucoma. So when we think about the overall risk profile, this is an individual that I would watch over time without a lowering of intraocular pressure. There isn't enough for me to cross that threshold to consider this patient as having glaucomatous disease.
I completely agree with you. And I always have an issue when I don't know what the untreated pressure is. Like, how do I know that the drop he's on, latanoprost, is actually doing anything good for him? And so I have the same approach as you. I actually recommended doing a washout of latanoprost, reestablishing a baseline untreated pressure, and going from there. If he happens to progress from there on out, my initial treatment would then be SLT, as opposed to actually putting him back on latanoprost would be my preference. So just some summary slides here on traumatic optic neuropathy. We know that traumatic optic neuropathy can result not only to trauma to the globe itself, but also to the head or to the orbit. And it could be even minor trauma. It doesn't have to be anything severe, perhaps like our patient had. The trauma usually involves the frontal bone and is a result of indirect forces that are transmitted to the orbital apex and therefore causes optic nerve damage. In traumatic optic neuropathy, the nerve fiber layer and GCC loss typically begins around 2 weeks after the trauma, and then it's going to plateau and stable at about 20 weeks. The pattern of loss with traumatic optic neuropathy tends to be more diffuse, like our patient had, than glaucomatous loss, which is expected to cause mostly superior and inferior nerve fiber layer damage.
You know, bottom line, when we're talking about differentiating suspicious optic nerves that we're concerned about glaucoma versus another pathology or another disease process, you know, what I think we've really seen is that we need to take the time that we truly need to establish that appropriate diagnosis, and to never rely on that first test or an individual test alone. And, you know, the qualities of ourselves as clinicians, you know, we really do have to rely on and understand that while our technology is excellent, it's really about how it's utilized in the hands of ourselves as clinicians. So Carolyn, wonderful to join you tonight. Great to work with you, and look forward to doing it again.
Looking forward to working with you in the future again too, Jessica. Thank you so much, and have a good evening, everyone.
Wow, what an awesome lecture. Thank you both so much for that. You know, there are so many cases that we all get referred that we wonder, is this glaucoma or is this not glaucoma? And it's really hard. And I think you guys did a really nice job showing that the main thing you need is time, because sometimes you just have to follow these patients for a decade before it even turns into anything. So I wanted to ask you, Jess, you were talking about the high myope and the challenges of diagnosing glaucoma in the high myope. And sometimes all you can do is modify the one modifiable risk factor of high pressure. What do you do if somebody comes in, they look exactly like glaucoma, but their pressures are 13 every time you see them?
That's a really interesting clinical circumstance. And we do see that whether they're highly myopic or not. In the case of a high myope, it's something important to keep in mind that inferior temporal nerve fiber layer can be damaged just due to disc tilt. So there can be structural change, there can be functional change that appears as glaucoma that is truly just to that myopic insertion of the optic disc. When the pressure is low, we're talking 13, there isn't a significant risk factor of thin central corneal thickness. These are patients that we discuss the options, and I tend to lead and lean towards observation rather than treatment in these cases. When we think about the overall risk of disease development and progression, thinking about that overall risk analysis, low pressure, suspicious nerve with the question of whether or not that is functional change due to glaucomatous disease or just their myopic disease, I tend to err on the side of observation.
I think nowadays too, it's much easier with like the iCare home device to get like serial tonometry. So maybe you're seeing a patient that has a normal pressure when they're in your chair, but who knows what it is, like early in the morning and that. And so I think that's something also to consider when you're dealing with any case of like normal tension glaucoma that's perhaps progressing despite what seems to be adequate IOP therapy.
Yeah, I fully agree with that. The iCare home has been very helpful in these normal tensive glaucoma patients. And on the same topic of them, in terms of masqueraders, one thing that I always struggle with is when a patient comes in and they're theoretically well controlled from a pressure standpoint, but they have a little disc hemorrhage. What do you guys make of those? Do you change your management if they have a disc hemorrhage?
Yeah, so certainly I think a disc hemorrhage is a sign that there is a potential for progression there. There is an increased risk for progression. And so it's someone that if I think has overt glaucoma, I'm going to start treating, or if I'm already treating for glaucoma, I may add an additional medication or be more vigilant, monitoring them a little bit more closely. But I think there's some questions, probably like a mechanical compression of the lamina that's like damaging a capillary. So maybe the damage is already done. It's hard to say.
Yeah, I think I fall under that category to say once I see a disc hemorrhage, I truly do believe that is already the sign that there has been mechanical change that has happened. Now, whether or not, if you decide to lower the pressure further or not, I think it's the understanding to say that change has happened. So maybe instead of or prior to jumping to add another treatment, have a really honest discussion with your patient about adherence. We know it is such a challenge for individuals to consistently use multiple medications on a daily basis, including their IOP lowering medications. So often that's evidence that I bring to the patient to say, here's what we have. Now, what can we do as a team a little bit better to maybe really manage this disease, even just to improve what we're already doing?
I think a disc hemorrhage in general, though, is a reassuring sign that you're dealing with glaucoma most likely versus something else. Like the only other something else I consider in a case like that is probably like non-arteritic ischemic optic neuropathy, which should be associated with like some sort of disc edema, usually sectoral, So if you have a disc hemorrhage and something that looks like sort of cupped disc, you can be reassured that this is probably glaucoma versus some compressive optic neuropathy or some other masquerader.
Yeah, and the other thing that I think about from a vascular standpoint is sometimes you get a patient who comes in and they're notched out in one area. Maybe it's a supratemporal notch, and everything else is just so rock solid, stable forever. And they're a little bit of a vasculopath. Sometimes I wonder, they just have an artery occlusion like that we didn't detect a while ago. And those are difficult patients too, because you catch a clear nerve fiber defect. But what do you do with them? Would you guys just follow them if their pressures were normal?
I would get OCT angiography personally. I mean, I love incorporating OCT angiography into these glaucoma masquerader cases, because if it was truly a branched retinal artery occlusion that happened in the past, you're going to have permanent non-perfusion in that area of the retina, even if the vasculature looks semi-okay. I mean, so I think that would add a lot of value there. And then if which case it was just an old branched retinal artery occlusion, I'm going to do an embolic workup non-urgently, but just watch closely.
That's a great pearl.
I think we're trying to figure out how to incorporate OCT angiography into the management of our patients with retinal disease, of course, and optic nerve disease. And, we're lucky to have these tools. And I really do think that we're still just figuring out how this can be an additional biomarker for disease development or progression.
Couldn't agree more. Well, thank you both so much. We're going to wrap it up here. And this actually brings us to the absolute end of our day. It's been a wonderful day in the implementation track. We started talking about OCTs and visual fields, and we ended talking about OCTs and visual fields in people who may or may not have glaucoma. Throughout the day, we talked about the interventional mindset in glaucoma, bringing a patient's pressure down by using your own hands to do so. We've talked about the Hydrus, we talked about the Omni, and then Dr. Samuelson told us all about what glaucoma might look like in the coming years with advancing technology. Dr. Sahar Badrood also showed us what she thinks glaucoma is going to look like in 2030. And it truly was just such a wonderful day. Tomorrow, we've got another full packed day of lectures. We're going to talk about drug delivery. We're going to talk about diagnostics, and we've got a whole day worth of lectures. So thank you all so much for spending your time with us today. Have a wonderful rest of your Friday, and we will see you all soon.